Awesome. Okay. Hi, everybody. It's great to see you all here. Welcome from WACh. This is one of our Breakfast with WACh talks. For those of you who don't know Breakfast with WACh, this is really a privilege that WACh is able to invite speakers from around the world, around academic institutions, ministries of health, etc., to share their work. And today we're really excited to welcome Dr. Anita Shet from the Department of International Health at Johns Hopkins. And she is a professor in the Department of International Health and director of child health at the International Vaccine Access Center. She'll correct me if I get anything wrong. She's a pediatrician, an infectious disease doctor, and a public health specialist whose work focuses on childhood infections and health equity. So, of course, a lot of intersections with the work we do within WACh, which focuses on the health of women, adolescents, and children, with a lot of infectious disease focus. In India, she established one of the country's first public-private antiretroviral treatment clinics, providing care to over 10,000 individuals and shaping national HIV guidelines on early ART, nutrition, and viral load monitoring. And her work includes shaping HIV care in India and enhancing adolescent HIV outcomes. That's one of her many expertise areas that she's been working in. So it's with great privilege that we welcome Dr. Anita Shet. Thank you.
Thank you, everyone, and good morning to all of you and to the ones online. I'm delighted to be here and take you through this journey that I was fortunate to experience. It's been quite a ride to grow with the children of the millennial children in India born with HIV. So we'll talk about the whole journey from survival to selfhood. So just to jump right in, I want to go back into a few years back in 2002. I'm just trying to make the slides move. 2002. So this is a rural area in Karnataka in South India, in a little village called Hoskote, where a boy was born in one of the households there. Of course, there was great joy when he was born, but a few years later, his father died. And then a few years after that, his mother died as well. And then his relatives took him in. But when he fell sick and he was taken to the hospital and diagnosed with having HIV, the relatives didn't want to have him anymore. And then he found himself at the doorsteps of a childcare institution. And that's when I met him a few years later. But this is a story that's repeated over and over again in many households after households in India back in the 90s and the early 2000s. This is a picture I've taken from a blog that I came across recently by a journalist who quoted this mother who was not doing well at all. She was worried about what will happen to my children after I die. And this was such a common scenario in those days and really heartbreaking. But at the same time, there was some developments that were taking place in the 80s. So around the time in America, after HIV was discovered and drugs were being developed, there was more acceptance of this condition. But at that time, the Indian government and the general public was in denial. This was a very moralistic society, so of course HIV has no place there. But there was this brave woman physician, Dr. Suniti Solomon, who, with her grad student, felt that they had to do something about it because they were seeing the cases. So she went out there to the sex workers that she was working with and drew some blood samples from them. Kept them in her own refrigerator because there was no place to keep them. And then she went to CMC Vellore, which was a lab at that time that was doing ELISA. It was the only place that was doing these tests. And when they did the ELISA test, they found that 6 out of the 10 samples were actually positive. So it was a shock, but not entirely surprising. But of course, this was met with a lot of skepticism. So she sent the samples over to the US to actually the lab of Dr. Tom Quinn in Johns Hopkins. And they were one of the few labs that was doing a Western blot at that time, and the diagnosis was confirmed. There was a furor at that time, and the government didn't quite accept it, but it slowly made its way to the public and was accepted over time. But really, in those early days, in the mid-90s to the mid-2000s, that was when the cases of HIV, the new incidence cases, peaked, and it stayed elevated through the mid-2000s. This was a retrospective epidemiological analysis using this joint point regression to identify the number of cases. So in 1997, India had an estimated millions of people living with HIV at that time. This was about 4 million, and this was a report by the UNAIDS in 1998. Children were about 7% of the total population. But the policy evolved too at that time. So soon after the acceptance in 1992, the National AIDS Control Program, NACP1, was made, and this mostly had a prevention focus. And then by 1999, there was NACP2 that had limited ART access. But the social context at that time was still quite stark. There was, especially for children, stigma was rife. There were children without parents, lack of any pediatric medications at that time. And you can see these are some news clippings where the doors were closed in schools, in healthcare centers as well. So it was a very difficult time at that time to be living with HIV. And I remember when I went back after my training to work in India, visiting some of these childcare institutions. One of the caregivers said to me that we have no drugs for children, only hope and empathy. But we knew that at that time, without medication, it was a life sentence being born with HIV. So the little boy that I met when I went to work at these childcare institutions, he, statistically speaking, he only had a coin flip chance of surviving past his 5th birthday. Right? So we know that without treatment, by the age of 5 years, 50% of the children would have died. This is a landmark study that was done by the UK research group that looked at children from the time of birth all the way to 2 to 3 years. This was before the ART era, so they were not treated at that time. So by the age of 1 year, if you look at the green line, the green line represented children who were born with HIV, and the red line, that's down below, represented children who were not affected at birth. So 35% of the children died by the time they were 1 year old, and 50% died by the time they were 2 to 3 years. So treatment was critical, although we didn't have it at that time, but we knew that the disease progression was very rapid in children. By contrast, the median survival time for adults was much longer. Here was a study which is a multi-center study in the US, following 3,800 adults in East and South Africa, Haiti, and Thailand, that looked at the median survival time from seroconversion up to the time that they had symptoms. And this was 10 years and above, and very similar in high-income settings as well. So this made me think at that time, so why do children with HIV have a much lower probability of survival? Why was disease progression so much more rapid? So if we look at the natural history of HIV in children, this is actually a graph showing the natural history in adults. So you have time on the x-axis, and the blue line represents the sleep, which represents the progression in levels, and then the viral load is represented in the red line, z-axis. So soon after infection, there's a very steep rise in viral replication for about a few weeks, 2 to 4 weeks. And then it comes down and reaches some sort of set point, even without treatment in adults. And then it stays at that set point for about 8 to 10 years, and then symptoms start occurring when the CD4 levels drop. So this is typically seen in adults. But in children, that entire period is squished into 3 to 5 years of disease progression. Very well illustrated by this study that was the Pediatric Spectrum Disease Project, coordinated by the CDC, that followed children in 7 geographical areas in the US. And they found that the median time from birth to moderate symptoms was just 2 years, and to severe symptoms of death is about 5 to 6 years. So this was well illustrated epidemiologically. To try and understand why this was happening, why were children different? Some of the reasons that I loved as we were looking at this field and these concepts. One is that the adaptive immune system in children, in infants, is just not fully developed, particularly the thymus. The thymus is at this very critical stage where the naive T cells are being adapted, and this would be interrupted with the viral infection. So the thymus will develop in the way it should. The early exposure to viral antigens can also induce this concept of immune tolerance rather than immune defense. And this sort of limits the whole control issue. And that can explain this big rise in viral loads in infants that we see. Usually these viral loads are 10 times the levels that one sees in adults. So it's really difficult to control at that point. The other reason is also the route of infection in infants. Usually they're infected intrapartum or during or post-delivery through breast milk. And the inoculum of the virus is much higher compared to sexual transmission or parental transmission. So a lot of these reasons existed in infants. And the thing is, all of these reasons put infants at a disadvantage, right? But the thing is, it actually offers a silver lining. I'll talk about that a little later. That we came across much later, but before the guidelines were actually set. But there was a turning point at this time because around the time, the late 90s, treatment became available and it really transformed survival at that time. And survival became a thing that we could actually grasp our hands around. So if you look at the history, by 1987, just a few years after HIV was discovered, AZT or zidovudine was the first drug that was approved and utilized. But this was given as an IV in infants and really difficult. It was also toxic because we didn't really know the doses at that time. So it didn't work so well. It was also short-lived because it was a single drug. In the mid-90s, there were these exciting studies that were done by David Ho in his lab at Rockefeller. So I worked there a few years later. But the excitement of the 90s still is palpable because this was the time they started using protease inhibitors as the third drug and found that this cocktail therapy really prolonged survival at that time. And then so on. So with time, by 2004, there was a global rollout, and then we have excellent drugs at present. I'll come back to this history later. But all these drugs and the survival came at a price. Okay? Before 2000, the cost of ART for an individual was about 10,000 to 20,000 per year per person. And this was completely inaccessible to 90% of the people in the areas of the world that had a high burden of HIV. So it didn't really help those people. So survival was still a little bit out of reach at that time. But in 2001, there was unlikely disruptor, this fairly small pharmaceutical company based in Mumbai, Cipla, that really went into the face of all the rules existing at that time and started making generic antiretrovirals. They started making these 3 drugs that were the first line therapy at that time, stantidine, lamivudine, and that we have been at the cost of $350 per person per year, literally $1 a day. But the rest of the world, the global north, erupted in fury because the big pharma didn't really like this development. But this was an act of defiance that really changed the ethics of global health forever. Because there was this global domino effect. And soon after that, there was this declaration on the TRIPS Treaty in Doha. TRIPS is trade-related intellectual property rights in 2001. And they recognized countries' rights to make generics in the face of crisis. And of course, after that, it changed to their rights to make drugs, regardless of prices. And this really had an impact on many life-saving medications and vaccines. The Global Fund in 2002 also became empowered to use these generic drugs, as did PEPFAR in 2003. And they were able to have these large-scale programs because of these affordable generics that India and many other companies in the past also started making. So by 2004, the cost of ART had dropped to 97%, or by 97%. That was remarkable because now we had access to these drugs for children and they could start thinking about growing up, going to school and having dreams. And we were taken along in that journey. So in 2004, we look at the policy milestones. There was free ART that was launched by the government in India, and the rollout was taking place in all the different states in India that had high burden, particularly. And there were these fixed dose combinations that we could use for children. And at the same time, the prevention of parent-to-child transmission protocols also was rolled out as we started thinking about eliminating pediatric HIV. And this was a time that we were able to establish this antiretroviral treatment center at the Mission Hospital where I was working at that time. And what we learned at that time was about medical care in general. You know, the general thinking at that time, before that time, was that the doctor is at the center of care. But this was a multidisciplinary clinic where the doctor was actually quite peripheral. Patients would come meet the counselor, who was the most important individual or touch point at that time, as well as the pharmacy counselor, as well as the social worker. Because this was how one could think of sustainable HIV care. This was lifetime treatment, which really, in a way, changed the way we were providing care. And then over time, by 2017, there was a street all policy, and now there are over hundreds and 1,200 link ART centers in India. So people have wide access to drugs. So this was a remarkable development in the field of HIV, which didn't exactly pan out to other conditions, but now chronic illnesses are taking on this particular model. But back in 2009, when I was visiting as a pediatrician, providing care of these children, I realized that these children were my teachers in a way. So I learned a lot by just being with them and seeing how they were growing. One of the boys in particular would follow me around and ask me very curious questions. And one of the questions he asked me was about the virus itself. Why do we have this virus? Where did it come from? And how did it get to all of us? And I was thinking of the textbook kind of answer to give. Then I realized I didn't really know about the origin of the virus. So I went back and I looked. And I wanted to share that journey with you as well. I've thrown some dates here, and I don't know if you can think about what dates make sense when it comes to when did we first know about HIV. Can you think a little bit about that? Which date is the most significant? Or is it all of them, or just some of them? I mean, you can think about that and come back to it. But But really, I didn't know all this earlier before I started looking. But we know that the virus itself came from simian immune deficiency virus, or SIV. But it's a little bit of a misnomer because the I, which stands for immune deficiency, these are lentiviruses that have co-evolved with primates for millennia. And so they don't really make us sick. So they don't really have the immune deficiency symptoms that we see in humans. And there are many different species of the monkeys, of the primates that had different species of the SIVs. But it's when they made that cross-species jump that's shown the red arrows that it became pathogenic. So from the mangabey to the chimpanzee, it resulted in the SIV chimp virus, which did make them sick, and then it jumped to humans. So all of this was done using these studies called the molecular clock studies that looked at replication and going backwards in time, or the most recent common ancestor studies, or the MRCA studies. And this was a technique that developed in the 90s. And when we go back, we know that these SIVs and probably the HIV virus was circulating back in the late 19th century, so starting from 1880, 1890 onwards. And then sometime around the early 20th century, 1910, 1920 to 1930, was when we think that several events happened to make that jump from chimps to humans. Because of urbanization, because of colonization, and there were all these large-scale population movements across the continent. And it jumped from chimpanzees to monkeys. I forgot to mention that the picture that you're seeing in the background is the deep tropical forests of Cameroon and West Central Africa, where we think that the SIVs were circulating originally. And then there was this blood sample that was taken from Kinshasa in DRC that was stored actually in Dr. David Ho's lab. And that sample was taken from 1959. And they were able to find traces of HIV-1, one of the most common species of HIV that's circulating in humans, in that sample. So we know for certain that in 1959, this virus was found in humans. And then, of course, in 1981 was when the case report was published. This was, people started noticing clusters of cases. This was a case report, case series of 5 cases, Sisters Caroline. That was published. The article was first sent to NEJM and it was rejected, and then it was sent and published in the NFW. And then you know the history from there. So all of these dates were significant. And I realized that actually this virus was circulating in humans possibly for a century, a better part of a century, before we actually knew about it. So, you know, you think about why do we care about history, but knowing history helps us understand present and the future in a better way. And in a way, it helps us understand why it's so difficult to make a vaccine for HIV once we understood how the virus evolves. Anyway, I went back to this little boy and I told him a little bit of what I knew. And he listened intently, and I just remember saying, "Oh, so you mean it came from a monkey? Oh, monkey." He went back and continued to play. But, you know, at that time, I remember thinking that among all the children that we were taking care of and providing medical care, we were not treating the HIV by the pathogen directly. We were only treating the opportunistic infections. Because at that time, the guidelines were such that you were able to start antiretroviral treatment only when there was advanced clinical disease, so stage 3 or 4, or if the CD4 levels dropped to a very low level. So 200 cells was already low for adults, but it was very low for children. It really meant they've reached terminal stage. And that's when you start treatment, right? We knew it at that time, but we really couldn't do very much because the availability of drugs and the guidelines. But it really felt like there was this big forest fire raging, and all you had were a few sprinkles of water. So it wasn't really making a difference globally. But then there was this landmark study that really changed and created this paradigm shift, a SHARE study. This was conducted as a randomized controlled trial in South Africa. And this was looking at early treatment compared to the existing treatment according to the existing guidelines. So infants from birth, as soon as they were diagnosed, between 6 to 12 weeks, so before they were 3 months of age, once diagnosed, they were randomized into the arm that had immediate treatment and the arm that had deferred treatment or based on the guidelines. So if you look at the survival curve here, we have time on the x-axis. The early treatment arm is the red line, and the deferred treatment is the line. And even before the end of the trial, during the interim analysis, it was found that infants who were treated early on, as soon as they were diagnosed, they were started on treatment, they had a 76% reduction in mortality. So the trial was stopped even before it was completed because it was unethical to go on with the trial. And this created a big revolution in the way we saw, particularly in children. And the WHO updated their guidelines immediately and said all children under 2 should be started on treatment right away. And then that extended to older children in the next couple of years as well. We also had biology that kept up with this observation that we were seeing in children about it, prolonging their life with early treatment. Some of the studies that I was involved with in India, with the Indian Institute of Science, was looking at viral fitness. Now, viral fitness is a property of the virus that allows it to replicate in a sustainable way and makes them fit or makes them able to adapt to any immune attack that was happening. And when we looked at serial samples of children who were ART naive before they were started on treatment, we found that the fitness increases with age. In other words, infants had virus that wasn't really very good at replicating in a sustainable and in integrating into their latent reservoir. So one of the things that was special about HIV is that it's an RNA virus. And using reverse transcriptase, it makes DNA, and that DNA integrates with the host DNA. And it just remains quiet in these hidden places in the body, in lymph nodes and lymphatic tissue in the gut, and all these long-lived white cells, T cells. But that latent reservoir was able to be diminished with early treatment in infants. So there was that window of opportunity in infants which we don't have in adults because the virus is already fit at the time of transmission to be able to convert the condition into one that will not progress if you start treatment early. So that was one of the big benefits of starting early treatment in children, that you were able to have smaller viral reservoirs. There was also the ability to have better immune reconstitution when you start treatment early. And there was normalization of the CD4, CD8 ratios that happened, and improvement of the naive T cells, the T regulatory cells that we saw with early treatment. And later studies also showed that there was neuroprotection. MRI looked at these children and found that there were fewer abnormalities in children who were treated early. So there were all these benefits that went hand in hand, the biology as well as the epidemiological observations. So looking at that snapshot again of this ART revolution from the beginning, although children were started initially with a mono and dual therapy that didn't work out so well, went into triple treatment. And over time, especially in the current day, we have better regimens that don't have as much pill burden as they did back in the mid to late 2000s, when children had to take about 10 to 15 pills a day and some very bitter tasting syrups. Now we have a single pill a day, especially with the use of integrase inhibitors, a new class of drugs called, the most common one being dolutegravir or DTG, that's currently used. So it seems like from survival, we moved on to be able to extend life so that the children could live with some degree of dignity with these medications. Let me zoom out and look at overall from a national angle. There's a study called the Accelerate. It's a program by the USAID that had been going on for 5 years until the early part of this year. That focused on key populations and providing care and support. And orphans and vulnerable children actually fell within that category. And I was part of that team that looked specifically at OVCs, providing treatment support, adherence support, as well as care in terms of education and families. We did a retrospective analysis at the end of last year, looking at national level data the last 6 years. And we had about 12,000 children overall. And at the time of analysis, it was 9,000 because 17% had transitioned from the OVC program after they crossed 18 years of age, went to adult care. But when we looked at that entire cohort, 55% of them experienced parental loss in their childhood. 36% had lost one parent and 19% had lost both parents, mostly due to HIV. When we just looked at viral load or viral suppression, that's seen in the graph there. We have the years from 2018 to 2024, and over those 6 years, the viral load initially, viral suppression was much lower because our numbers were also low at that time because everyone was not getting viral tested. The viral suppression rate rose from 76% up to 90% in 2024. And the inflection point was actually seemed to be the introduction of DTG, a single 1 tablet a day regimen. That seemed to really help. And it was also statistically significant when we looked at viral suppression. So it seemed like we had crossed that barrier for viral suppression. Of course, there was that last mile of 10 to 20% of the children that were still not suppressed that had to be addressed. But, it made us think again about treatment. And even though viral suppression was happening, we realized that that was not the final frontier. It was not the destination. There were still many barriers to cross over until we reach where we want to reach and allow kids to grow up and live with dignity. So we had this adolescent cohort, 10 years back, no one expected them to live up to late adolescence and adulthood, but here they were, and taking medications well. But the transition was not happening in the way one would have expected. There were gaps, people were getting less engaged in care. There were disclosure dilemmas and adherence fatigue, fractured identities because children were not able to possibly with their past trauma or with their understanding of how to live in the world. And there was this potential for risky behaviors and mental health issues. But at that time, our own thinking of how to engage with these children also changed. And we began to engage them more as partners. And we incorporated the principles of community-based participatory research, where children were no longer patients or participants. They were actually partners and part of the table where we were discussing these things. We analyzed this in a more critical manner and looked at the 8 principles of community-based participatory care research to be able to identify how can we engage these children to the best possible way so that the community benefits. They're not just beneficiaries, but they're also partners that make decisions. So that was a big learning for us. And one of the things that came out is very eloquently put by one of the young adults in Hopkins. He said that we've been always told that things are impossible, but we want to change it, shift it to saying, I am possible. And that's how the I Am Possible Fellowship was created as a peer mentorship model. Very similar, we realized later, to models that were developing in other parts of the world, like in Zimbabwe. This one theory model is very similar, where you have the fellows or the peers who are able to provide support to the other peers who were paired with them and who were provided treatment support, adherence support, but also understanding what were the barriers in accessing schools or financial resources that were available. So here's the model that we have with fellows and the peers, and we realized that the fellows were also experiencing personal growth. It wasn't just unidirectional, but the growth was bidirectional. The peers who were receiving support by the fellows were also providing that energy and purpose back to the fellows. This was not happening in a vacuum. This was all within the socio-ecological model, where you had the individual peers and the fellows, as well as the caregivers, the institutional supervisors, and society as a whole. Once the barriers were addressed, they needed to get together to make this whole model work. But mental health emerged as a very important frontier that had to be addressed. This is a map of where we've been working in the last few years in southern India, in the states of Karnataka and Tamil Nadu. This was a cohort that began in the I Am Possible Fellowship, and after about a year, we had 206 of these adolescents with perinatally acquired HIV who we surveyed using validated questionnaires like the Patient Health Questionnaire and the GAD, the Generalized Anxiety Disorder, GAD-7. We also used a resilience survey, the CYRN, which is a validated survey scoring resilience in these children. The mean age of this cohort was 18 years, and most of 60% were male. They were on ART for about 10 years minimum on an average, and again, 90% of them were virally suppressed. But a large proportion of them, 91% of them, had experienced loss of one or both parents, and 43% lived in group homes. And when we looked at the GAD-7 and PHQ-9 and scored them as mild, moderate, or severe depression screening scores, 19% of them actually screened positive for moderate depression or anxiety, which was quite high and fell on the higher range when we looked at literature in other parts of the world. 15% had depression alone and 10% had anxiety. So we also found that loss of parents was associated with increased odds of anxiety, non-suppressed. Similarly, with resilience, we found that overall there was a score that seemed high, but when we looked at those that had lower scores, the last title, there was an increased association of those who were orphans or those who fell out of school. So there was really something that had to be addressed in a more integrated. And so we started thinking about transition measurement. So understanding readiness to transition from adolescence to adulthood, and we got together with the youth and designed this tool that tried to understand why it was such that 1 in 3 adolescents actually lost out from care once they transitioned into adult care. This was seen in some of the systematic reviews that happened in other parts of the world as well. What we identified was we tend to focus a lot on health, but what is really needed are these other social determinants, which include the vocational, that included the educational and the career pathway of these children, as well as housing and financial literacy. The things that we often take for granted, they're a little bit outside the purview of health workers, but very closely linked with supporting, preventing mental health conditions later on. And we felt that this was an iterative participating process where we really could integrate the principles of community-based participation. One of the other side interventions that started a couple of years ago and then now has taken on a life of its own was physical activity. It was a brainchild of one of the kids who grew up in the setting and was an athlete himself. Realized the joy of running and the ability of goal setting in a running exercise regimen to be able to bring about resilience. And in that manner, bring about better treatment adherence and healthcare and retention of care primarily. So we designed this intervention together where there was regular running and exercise activities every week with camps intermittently and with the goal of taking part in a running event once or twice a year. And we were amazed at the change that it brought about in these children when we looked at the first 150 of these young ones. We started at the age of 8 years, from the time they were able to provide assent to take part in these activities, up to 18 years. And we looked at the cohort, because the majority of them, and 90% violently suppressed, but the intervention seemed to really catch on, and they were able to sustain this in the last 12 months that we were able to run this. What we really found is that this was a gender transformative. In the beginning, when we started this intervention, we were told that the girls would run. Don't think that they would come, but they did. And once they came, we were able to really understand what were their barriers. So generally, girls in this setting, they were at the intersection of so many identities of vulnerability. They were adolescents or young women. They had lost parents, socioeconomic barriers. They were living in out-of-home care and with HIV. Even one of these barriers alone is enough to impact your health outcomes. Imagine all of them compounded together. But we built this running intervention on the self-determination theory that included autonomy, competency, and relatedness. Using this peer support, we had people from the community function as captains who would be role models for these children. And we found that over 6 months to a year, and we did a qualitative analysis. We didn't have time to do a full-fledged baseline and end-line analysis, but that's ongoing now. But we really found that it's helped in sustaining that motivation and to exercise as well as self-management of health in these girls. Now, we have some of the quotes that I've listed here, where one of them said, "When girls run, people judge them. They say, 'You are a girl, why are you running?'" And one of the other girls, here's another quote, where she said, "Running gives confidence in me whenever I do it. Like to do something or anything and be good at it." So that really made a difference, and we saw that this is a way in which we could actually create some degree of gender through this. So this is a journey so far. We talked about survival. In the end, we had people who are really achieving many things, despite going through all the barriers that they went through. This was really selfhood, I would say. We were able to understand or obtain agency that many of us sometimes take for granted. But for me personally, there were all these life lessons that I learned by going along with this journey. And if I could capture it overall, I have these 4 things that come to mind. In a way, one could think that we could apply to other areas as well. So we learned that medical care is not static. It's dynamic and it's constantly evolving enterprise. We know that biomedical victory can sometimes mask psychological defeat. But medicine, guidelines keep changing. What we know about one day can change the next day. And the story of pediatric HIV really mirrors humility in science, where we have to stay humble, where we know that things can change. We don't always know it all. Second lesson is that treatment alone is not care. There are these psychological frontiers that also need to be addressed. So when we think of providing care, it's not just medication, but it's also social, emotional, and psychological. So when you integrate all of that, it's like healing. The third lesson is that communities are not beneficiaries, they are actually co-creators. And when we do that, when we bring them to the table, and we're all there at an equal footing without much of a power imbalance, that's when we can actually see a difference in the community. And this is very critical in public health. And finally, what we learned together collectively is that public health is so much about equity, it's not so much about efficacy. We put a lot of importance on randomized trials and what works, but not about who it should work for. The time taken for ART to reach people that really had the highest burden was more than 10 years. It's kind of unconscionable. And we see that repeatedly. We used to see it in vaccines. Now that's changed. So in a way, we are moving towards better equity. These were all the lessons that we learned, that I learned during this journey. So I just want to thank you. I want to thank all, everyone who has been involved in this, particularly the children and young adults in India, where I worked for many years, my department and the funders over the years, colleagues, and my family played a big role in many of these interventions. So thank you so much for your attention.